I am excited to welcome Dr. Ospina for our Lunch with Docs today. And I know her title is Everything You Need to Know About Parkinson's You Learned in Kindergarten. I think it's something like that. There was a book by Robert Fulghum that Everything I Need to Know I Learned in Kindergarten. How many of you read this book or know which book I'm referring to? Such a great book, such words of wisdom for our lives, which I love that Dr. Ospina is kind of using that as a way to talk about Parkinson's disease. So I know she's got a great presentation for you. I want to invite you to open up your chat box. Let Dr. Ospina know where you're joining us from. Let us know where you're joining us from. And I'm Anissa with PMD Alliance. And for those of you who haven't had the pleasure of hearing Dr. Ospina, I am excited that you're meeting with her today. She is one of our movement disorder specialist partners we work with on a regular basis. She's done online programs with us, in-person programs with us. She's just been one of our key partners, and we always love hearing from her. As you will hear today, she does such a good job of connecting with people, and she always has such words of wisdom. And so I'm excited to hear this presentation, and I am going to go ahead and give this over to you, Dr. Ospina, and get us started because I know you have a lot to talk about.
Great, thanks, Anissa. So that's right, you know, it's hard to believe, but everything you need to know about your Parkinson's disease, you actually learned that in kindergarten and what your mom told you. So we'll get started. And then I welcome any questions while we're doing the talk. So you guys don't have to wait until the end of the chat. So if you have a question, just raise your hand, or Anissa knows how that stuff works, and she'll let me know what the question is, and I'm happy to address it at that time. So remember, if you have a question, probably many of you have the same question as well. Okay, so we'll get started here. Now I have two things. Okay. Okay, so is that working for everybody?
Okay. Looking good.
Okay. No. Okay, so we'll start with mom's words of wisdom. So there's the stuff we don't like to hear, but mom always said to eat your vegetables. And that's really true in Parkinson's disease. So not only because of the constipation that we have with Parkinson's disease, but we'll find out that the microbiome has a lot to do with Parkinson's disease. Remember, one of your very first symptoms of Parkinson's is the constipation. And many patients have that many years and sometimes decades before their diagnosis of Parkinson's disease. And remember that you have bradykinesia, which means slowness of movement. And that involves all of the muscles of the body, including the muscles of the gut. And because the gut moves slower, more fluid gets sucked out of your stool, the stool gets hard and you get constipated. And then that gastrocolic reflex doesn't work. So usually when you eat a meal, the stomach sends a message to the colon and says, hey, you know, I'm digesting all this stuff. I'm going to push it through the GI tract. You need to have a bowel movement to make room for everything. But if you haven't had a bowel movement in 2 or 3 or 4 days, that gastrocolic reflex doesn't work. And then everything sits in the stomach for a longer period of time. And then that's one of the reasons why patients have off periods, what we call delayed on. So you took your pill and it took an hour or 2 to kick in. And that's because everything is stuck in the stomach. And because 90% of the medicines that we use in Parkinson's disease are still pills that we take orally, you know, having that gut move as quickly as possible is really important for us, because if it's not moving quickly, then we're not absorbing the drugs efficiently. And remember, the drugs actually get us absorbed in the small intestine, not actually in the stomach. And if it's taking a very long time to transition from the stomach into the small intestine, you notice that as a delayed on, that, you know, didn't kick in 15 minutes, it kicked in an hour. And it's the reason why your doctor switches your medicine. So it's not that we're trying to pick the most expensive medicines at the pharmacy. We're trying to pick medicines that work like your normal brain and medicines that help us with that gastroparesis, what we call that slowed gut. So many times your doctor will migrate you to a once-a-day dopamine agonist, once-a-day MAOB inhibitor or COMT inhibitor, and then longer acting forms of levodopa like Rytari, so that we don't have to make that transition every 3 or 4 hours. We can make it once a day or in the form of Rytari every 4 or 5 hours and try to stretch that out as long as possible. And then the other reason that we want to avoid that gastroparesis is that we don't want you to be always thinking about, you know, the 6 alarms on your phone and when am I going to eat my meal and what am I going to eat with my meal. So we want you to divorce you from those alarms and divorce you from trying to think all of the time, well, how much protein can I have during the day? Should I have my protein at night? Should I eat an egg with breakfast? And so if you're just on once-a-day medicines or longer acting forms of the medicines, it's not so critical of what you ate and when you ate it. For our patients that are taking Sinemet or levodopa every 2 hours, then it's really critical, or they really notice that there's competition with the protein in their food and their levodopa. So remember, levodopa is made out of amino acids, a little of a protein, and it uses the same transporter as the amino acids or the protein in your food. So think of it, if you eat your breakfast, and we had one gentleman that his breakfast turned out to be 2 eggs and steak. And that's why his first dose of medicine took a very long time to kick in. And so think of it, your little amino acid transport is like a little elevator that goes from your tummy up into the brain. And if your steak and eggs gets there first, then your Sinemet has to wait until the next elevator to get back into the brain. And so that takes a little bit longer. So we always want your levodopa, your Sinemet, to be first in line and not have to have all of that competition with the protein in your food. So we know that fruits and fibers, those vegetables, that fiber helps us with the constipation. So the more fluids you're taking in, the more fiber you're taking, the better that constipation is going to be treated. And most of our patients, along with the fruit and the fiber in their diet, they're going to need something like Miralax to keep you on a regular basis. So we want you to be having a bowel movement at least once or twice, like every day or every other day, so that we don't get into trouble with that gastroparesis. And I just had a colonoscopy and had to take a bunch of Miralax, and it turns out that stuff doesn't taste like anything. So, you know, everybody always complains about it. But you know, if you just take a glass every day, put it in your juice or whatever you like to drink, and that keeps you regular, and then that's going to mean that we're going to be moving your gut, and we're going to be allowing your medicines to be absorbed more quickly. So lots of fruit and fiber to help with the constipation and help you absorb your medicines better.
Dr. Ospina, I did get a question about the use of prunes or prune juice for constipation. What do you think about that, and what kind of a dose would you recommend?
So those are all fine, Juice Plus, all of those things. Remember, the more fiber that you eat, the better off your gut is. And so the doses, you want your stools to come out like toothpaste. So you want to have enough fiber in your diet that you have regular bowel movements, but not so much that you have liquid stools or diarrhea. So you want to titrate, and then you'll need to titrate that dose or adjust the dose depending on how much fiber you have. So some days you have more fiber, some days you have less, and so you need a little bit more Miralax. And then everybody is different. So some people do just fine with 1 cup full of Miralax every day. Some people need it twice a day. Some people only need it every other day. So you just have to see what your body is like and how much Miralax you need in your diet. And then adjust it accordingly. But you want to just have it come out like toothpaste so that it's comfortable, easy, you're not bloated, you don't have gas pains. And then that means that your gut is moving quickly and efficiently, and so that when you take your medicines, they're not getting stuck here in the stomach. They need to come in here into the small intestine where they actually get absorbed, and that's where these amino acid transporters are, where all your medicines and all your food, once it's digested here, gets absorbed and you're able to use it.
And another question.
Sure. Yeah.
the use of probiotics. Do they help constipation? One person's saying they've tried them. It seems that it's gotten better. They don't know if it's correlated or coincidental.
Yeah, so basically we want to have prebiotics. So prebiotics are the fiber that's in your diet, and that's what the good bacteria want to eat. So I think we have a slide on that. So let me get to that in the next slide. And so that, remember how we were talking about delayed on? Here's somebody who took their medicine 90 minutes ago. This is a patient who was going to have an EGD. They had taken their medicine an hour and a half ago. And here, look at, here's their yellow cinnamon completely intact. It's not even digested or chewed up yet. And so that's a patient who took their medicine and says, hey, nothing happened. And nothing happened because it got stuck in the stomach. And it's over here and it didn't get into here. So we want to avoid that as a reason why you're having more off periods during the day, and to have less delayed on. So we're going to talk about the microbiome and prebiotics and probiotics. And so it turns out that, we used to think that the bacteria in our body and on our skin was just sort of a nuisance, and that, we didn't really need it and we should get rid of it. And it turns out that the microbiome does a lot of stuff for us, and that there's 10 trillion microbiota in and on our body. So basically, we're a bunch of bacteria held together by a little sort of bag of water with a name of a human on it. So it's about 3% of our body mass. And the microbiome is super important in developing your immune system in early infancy. So it turns out that the maternal breast milk, actually 80% of that breast milk is actually sugars that are meant for the microbiome. The baby itself can't digest those sugars. They're meant to feed the microbiome. And so that's how important it is that most of the breast milk is actually feeding the microbiome rather than the baby. And so what does that microbiome do for us? So it extracts nutrients for us. So it makes vitamins like B12, vitamin K. It converts inactive vitamin D to the active form. It makes neurotransmitters like serotonin, norepinephrine, and GABA. So it's super important for us. It regulates your metabolism, so you're less likely to develop diabetes and high cholesterol if you have a good microbiome. And then it regulates and it shapes our immune system. So basically, we need to have contact with these bacteria and viruses and that sort of thing to mature your immune system, and so that you don't develop things like autoimmune diseases like asthma and lupus and those sorts of things. So basically, every baby on their first birthday really should just get a jar of dirt, and so that we can really improve their immune system. And so then we talked about the oligosaccharides in the breast milk are really to feed the microbiome. And then, in our gut, we've got this little big brain over here, but it turns out that in our gut, we have a little brain. There's a lot of neural tissue that's surrounding the gut, and that it does a lot of importance, and it talks to the microbiome back and forth with these neurotransmitters like serotonin, norepinephrine, and GABA. And it's the reason why we say, I have a gut feeling. And now we think that Parkinson's disease actually starts in the gut, or in some people in the nose, and then travels up the vagus nerve up into the brain, so that it doesn't start in the brain. And that's why when you come and see the neurologist with your motor symptoms of Parkinson's disease, those are things like tremor, rigidity, bradykinesia, or slowness of movement, or the trouble with gait and balance, you've already had Parkinson's 10 or 15 years. That's the premotor phase of the Parkinson's disease, where you've had the constipation, you have anosmia, your loss of sense of smell, you can have trouble with anxiety or depression. So remember that the microbiome has to do with these neurotransmitters, and so you're more likely to have anxiety and depression if your levels of serotonin and norepinephrine are low. Patients can have restless leg syndrome, and patients can have RBD, or REM sleep behavior disorder, where you act out your dreams. And that can be present many years and sometimes decades before the Parkinson's is diagnosed with the motor symptoms. And so we think that it may start in the gut and in those neurons that are surrounding the gut in that little brain. And so how does it get in there? So here, this is our microbiome. See all of these little different colors? That's all your bacteria, virus, archaea, all these sorts of things that do all these wonderful things for us. And then here's your gut lining. The green thing here is your gut lining. And then here is sort of the the neural tissue that surrounds the gut. So that your little brain that's around your GI tract. And so what happens and it turns out that the microbiome in Parkinson's disease is actually different from patients who don't have Parkinson's disease. And within the Parkinson's community, patients who have tremor predominant Parkinson's versus rigid predominant Parkinson's, it turns out that their microbiome is different as well. And so we don't know what came first, the chicken or the egg, but we know that what we want to do is we want to feed the good bacteria. And the way to feed the good bacteria is to feed it fiber. That's the prebiotics. And we don't know exactly who the good bacteria are yet. So that's why we don't know exactly the probiotics. So when you go buy in probiotics at the supermarket, many times because it's not regulated like with the FDA, like vitamins and those sorts of things, we don't know what you're getting and if it's actually the milligrams it says on the bottle, and if it's the actual bacteria that it says on the bottle. So it's not very well regulated. And it turns out that your probiotics, most of them, you just poop them out 24, 48 hours later. So they don't really stick around. So what we want to do is just like we want to do, when we fertilize a field, you fertilize until the field, that's the prebiotic, the fiber. And then when you throw the seeds into the field, they're more likely to grow if it's already fertilized. So that when you put your probiotics, which are the seeds, then they're going to grow if it's a good environment for those probiotics to take place. So really we want to concentrate on the prebiotics, which is the fiber. And eventually, I think, in the next 10 years, part of our treatment for Parkinson's disease will be some form of changing your microbiome, just like we do fecal transplants for patients with C. diff. Once we figure out who the good bacteria are, we're going to seed those PD patients, that microbiome, with that good bacteria. And then what happens with the bad bacteria? What do? If they don't have this fiber to eat, what happens? They eat the small chain fatty acids that make the lining of this mucosal lining. And so when they eat those small chain fatty acids, you cause what's called a leaky gut, so that more stuff is likely to make it through the outside. Remember, this has contact with the outside environment. So every time you eat something, it's going through the gut, and that's the outside coming into contact with the inside of your body. So if you eat stuff that has herbicides, pesticides, then it's more likely to get through the gut and come over here and come into contact with the neurons in your gut, and then cause the misfolding of the alpha-synuclein over here, which then starts to march up your vagus nerve and make it up into the brain 20 years later. So we want to keep this gut lining intact as much as possible so the bad stuff doesn't get through. And then we're less likely to have the alpha-synuclein make it up into the brain. And so we want to keep that gut lining as well, working as well as we can. So any questions that you guys have about that? And so remember, we're not just eating for ourselves, just like the mom is not just feeding the baby, we're eating for all our little microbiome friends that are in our gut, which are actually doing lots of good stuff for us. And so that if we're thinking, why is dairy supposedly, bad for PD? Why does it cause inflammation? It could be that it's really not the dairy itself that's the problem. It's that the cow who made that milk for you, or made the cheese, was eating grass or grains that had pesticides like paraquat on it. And then that's how it made it into our gut and then passed the gut lining into our nervous system. So we want to be careful of what we eat and feed the good bacteria, because they're sort of our first line of defense from all the pollutants that we have in our environment. And then the butyrate, let me just finish here. So the butyrates are, patients who eat lots of red meat, the red meat, it produces butyrates. Actually, the red meat, so you want to have the good bacteria so that they can make this butyrates, and then they have more anti-inflammatory properties in your gut, and you're less likely, so when you eat the red meat, that have plaques in your blood vessels. Go ahead, Anissa.
Yeah, I was going to say there was a few questions that's going along with what you're saying. So one person wanted to know, so is this why you should eat mostly organic, or if you're going to eat meat, grass-fed?
So remember that organic, so rotenone is an organic pesticide. So just eating organic doesn't mean that you're home free. So you want to just eat good stuff. So your microbiome, your body wants fruits and fibers. It prefers to get the minerals and vitamins that way instead of like in a multivitamin tablet. And so we want to feed the good bacteria. So the good bacteria grows and it pushes out the bad bacteria. So that's what happens in C. diff. C. diff, the bad bacteria takes over and then it causes all that horrible diarrhea. And then we have to seed you with the good bacteria to push out that C. diff because it's resistance to vancomycin. And then that's how we get rid of that infection. So I would say that, you know, in our environment, it's almost impossible to get away from pollutants or herbicides or pesticides. You know, there are pollutants all over, you know, the air, you know, we did get rid of lead in the automobile, you know, on the car gas, but it's still, you know, in the airplane, in the fuel that's used for airplanes. So that causes a lot of the air pollution and trouble with Parkinson's disease. And the same thing with herbicides and pesticides, they're kind of everywhere. So I would just say, eat healthy. Just what your mom said, eat your fruits and vegetables, eat healthy food. Remember, you know, like if you just eat donuts, which is what you like to eat, it just feeds the bad bacteria, and then the bacteria then has to eat the lining of your mucosal lining to get those short chain fatty acids.
Well, I have a quick question about that. If you have the leaky gut, can you fix it?
So you can fix it by fixing the bacteria.
Mm-hmm.
So if they stop chomping on your mucosal lining, then you're going to regrow it, and then you're going to feed them the fiber that they want, and they're going to leave your lining alone.
And we need some clarification. Somebody wants to know, what is C. diff?
Oh, so C. diff is an infection of the gut. So some patients, many times when they've been in the hospital and they get tons of antibiotics, you know, we just kill off all of their microbiome in the gut. And so when we kill off all the good bacteria, then the bad bacteria like C. diff takes over, and it takes over the gut, and it causes this horrible explosive diarrhea. And now it's resistant to vancomycin, one of the antibiotics that we used to use for that. And so in those patients where vancomycin doesn't work, we actually have to do a fecal transplant for those patients. So in the past, you would do a colonoscopy and give them the stool of a normal patient. Now it comes in little capsules, and then you take 26 of these little capsules and you reseed your gut with the good bacteria, and it pushes out the C. diff, the bad bacteria.
That's fantastic. And then I think there was a question, I'm scrolling up here, about the fecal, is there any status of fecal transplant for people with Parkinson's?
Yeah, so no, so that there's no clinical trial. So we're in sort of the very early stages in figuring out the microbiome in Parkinson's disease. But I think that in 10 years from now, once we figure out who the good agents are for PD, that will be part of our treatment. So it's very early days. They're looking at it for things like ulcerative colitis, inflammatory bowel disease. Right now, it's only being used in patients with C. diff that are vancomycin resistant. But, you know, this is sort of super exciting research that's happening now, and we're going to learn more and more about it.
And one last question, and we'll let you move on. When you were talking about the bacteria, the good bacteria versus the bad bacteria, can flatulence be related to one or the other? Is there any way to reduce that?
No, so flatulence is good. That means that your bacteria is working and it's doing what it's supposed to do. It's eating the fiber in your diet. So I know it's socially inappropriate, but if you're having flatulence, then that's actually a good thing. So what you want is to feed them the fiber that can produce flatulence. But remember, you know, we're not eating for ourselves. We're eating for trillions, and we want to feed our good bacteria. And then nap time. So eating your vegetables, you know, mom always told you to eat your vegetables. Then always, it's very important to take a nap when you're in kindergarten after you've gone to recess. And so sleep is affected in Parkinson's disease. And as all of you out there know, we have very little things that we can do for your sleep problems and sleep fragmentation in Parkinson's, but sleep is super important in the protection of Parkinson's disease. So, most patients, if you live out a normal lifespan, you spend a third of your life asleep. That translates into 25 to 30 years of sleep. That's a really long time. So it must be doing something super important that we're going to spend a third of our life actually sleeping. So what's actually going on in there? So it turns out that sleep is very restorative. So that's when the healing of the body is taking place. You sprained your ankle during the day, that healing, restorative healing is going to happen during sleep. Learning and memory is consolidated into during sleep, your deep sleep. And so that when you turn your short-term memory into long-term memory, that's all happening during sleep. If you're learning new things, so let's say you learn a new crochet thing, or you learn a new piano lesson or a new recipe, if you sleep on it, then you're going to be better at the next day. And that includes motor things like skiing and playing the piano and that sort of thing. And then sleep is when all of the housekeeping happens in the Parkinson in your brain. So it's your brain does all the cleaning out of misfolded proteins, of which Parkinson's has alpha-synuclein as one of those misfolded proteins. So if you're not sleeping enough, then that housekeeping isn't happening. And then the cells get clogged up with all this stuff and they don't work efficiently. And so that's what we want to do. We want to clear that misfolded protein as much as possible. And that's one of the problems in Parkinson's disease, is that misfolded protein isn't able to be cleared well enough, and it causes the cells to die off. And so we know that during stage 3 of sleep, your sort of delta sleep is with growth hormone is released. So that's why our teenagers sleep so much. They sleep a long time, but because they're going to be growing 5 inches in 1 year. And then that's when it's repairing itself. And then lack of sleep, we know, can lead to increases in things like incidence of obesity, diabetes, and heart disease, not to mention, trouble with irritability and trouble with short-term memory.
And how much is a good night of sleep? Like, how much sleep should someone be getting a night?
So everybody's different. And remember that you don't have to get all of your sleep all at once. So you don't have to get 8 hours all at once. So you can get 3 or 4 at one time, be up for 2 hours, and get another 3 or 4 hours of sleep a little bit later. So it's only after the Industrial Revolution that we ended up, and everybody had to go work at a factory, that we ended up sleeping the way we do now. Before, you had sort of a little sleep and then a later sleep, and you were up for 2 or 3 hours in the middle of the night. And so that's something that happens in Parkinson's disease. You have that sleep fragmentation, and patients get kind of worried of like, oh my gosh, I'm waking up every day at 3 o'clock in the morning, and then I'm up for 2 hours and then I sleep again. And yeah, that's fine. So you can get them in little chunks of time. And remember that sleep fragmentation is common in Parkinson's disease because you have low levels of dopamine. And when your levels of dopamine are low, that causes your PD motor symptoms to come back as well. So rigidity and stiffness, that wakes you up. You go to the bathroom and you come back to bed and you can't fall asleep again because you're too stiff and rigid. Your body can't relax enough to fall asleep. So again, it's the reason why your doctor likes to use once-a-day medicines, or sometimes add medicines during the middle of the night to keep those levels of dopamine stable, so you're not peaking and troughing and wearing off in the middle of the night and have that as a cause for sleep fragmentation. And so we'll go over the different problems that PD patients have during sleep. The most common that we talked about was REM sleep behavior disorder, that can be present many years and sometimes decades before your diagnosis of Parkinson's disease. Oops. Oh, there's the IT guy trying to fix my computer. And so when you go to sleep and you go to REM sleep, which is your dream sleep, usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis no longer takes place. So you're free to talk, yell, scream, kick, and punch, and act out your dreams. You can hit your bed partner. Yeah, I'm in the middle of this thing. I'm sorry.
This is what happens when you're busy and in demand.
Exactly. And so that you're free to act out your dreams. And then usually this is a problem for the bed partner. They're the ones getting kicked and punched and waking up with the screams and everything. But many times the patient can also fall out of bed. I had a patient yesterday who broke their nose and has sort of raccoon eyes because they fell out of bed. You can hit your arm against the nightstand. And so in those cases, we put a bed rail. In very severe cases, we have you sleep in a sleeping bag, so you're less likely to act out and break stuff and fall out of bed. And then we can treat it with things like melatonin and clonazepam to treat the RBD. But usually it's more of a problem for the bed partner than the Parkinson's patients. And you don't have to wake up the PD patient. They're not going to remember any of the dreams the next day. And it turns out that for both men and women, during REM is your brain is practicing getting away from a threat. And so that's why it turns out that all of these dreams seem to be like nightmares, and there's lots of running and kicking and screaming and that sort of thing, is because you're practicing getting away from a threat. So whether it's, some kind of robber or ISIS or a bear or mountain lion, that sort of thing, that's what happens. And so that's why they tend to be more violent, because your brain is practicing getting away from a threat. So your brain is doing lots of things at night that you didn't think were going on, but it's trying to keep you alive for the rest of the day when you are awake. And then restless leg syndrome are very common in Parkinson's disease. So most patients that have RBD or REM sleep behavior disorder go on to develop Parkinson's disease. If you have restless leg syndrome, that does not mean that you're going to get Parkinson's disease in the future. But most patients with Parkinson's have restless legs. And there's many other reasons why you could have restless legs. So you could be pregnant, you could have iron deficiency anemia, you could have a renal disorder. So RLS is super common in PD, but doesn't lead to PD. RBD many times leads to Parkinson's disease. And so as we talked about, so these are your premotor symptoms that you have in Parkinson's: RBD, the RLS, depression, constipation, and anosmia. So in the future, once we get something that's neuroprotective, just like all 50-year-olds get a colonoscopy and a mammogram, today we have things like the DAT scan and the skin test for alpha-synuclein. Any patient who has these risk factors then would go on to have a DAT scan or a skin test for alpha-synuclein. If it's positive, then we would go ahead and give you that neuroprotective agent, whatever that turns out to be, or something for your microbiome. So whenever we figure out the little nanobots that do origami and refold your alpha-synuclein, so that we can stop the Parkinson's disease in the gut. So we can make the diagnosis early. We just don't have these little nanobots yet.
I have a couple questions.
Go
real
ahead.
Quick. So you were talking about some of the prodromal symptoms, with REM sleep being one of them. So if someone has been a poor sleeper most of their life, they want to know, could this have caused PD, or could this have maybe just been an early indicator?
Yeah, so poor sleeping isn't going to cause Parkinson's disease. It could be an indicator, but it would be more the RBD would be more of an indicator. So, everybody's different. Some people are night owls. Some people wake up early in the morning. Some people sleep for 10 hours and some people only sleep for 4 hours. But certainly once you get Parkinson's disease, your sleep is interrupted and it's not as good quality as it was before. And then when you get on medications and you start to have the motor fluctuations, the wearing off, then you have sleep fragmentation because you're wearing off.
And the restless leg syndrome and pregnancy, how are they tied?
So we don't know probably an OBGYN would know what the cause is, but we know that patients with pregnancy can have restless legs, just like you can have iron deficiency anemia. And if you have renal disease, that can also cause restless legs. And the restless legs, it's sort of a feeling uncomfortable, a kind of a weird feeling when you sit down or lie down. And then when you get up and start to walk around, it feels better. And you can also not have it just in the legs, but you can have it in the arms as well. And it can be not only just at night, but you can have it in throughout the day. And so that's why we like to use once a day medicines like the rotigotine or the Nupro patch to get you better coverage during the 24-hour period. And you have to don't have to start taking the medicine so early during the day. And they do quite well with small doses of dopamine agonists like Nupro, Mirapex, and Requip. And the Cinemet also helps you with the restless leg syndrome.
Can
So
electric feeling in the legs be part of that experience with restless leg?
what was that?
An electric feeling in the
Yep.
legs?
So it's all sorts of weird feelings. So you can feel an electric feeling. It's patients have a very difficult time describing it. They just say it just feels weird. And when they start to walk, then it goes away. And they can feel it in the hands as well. So you can feel like pins and needles, like electric shock or pain. And then it's only relieved by getting up and walking around. So it occurs in over 10 million people, and it's more common in women than men. And so the treatments, as we talked about, are dopamine agonist, and we like to use once a day agonists so that we have better coverage throughout the day and night. And so what you'll find is that it'll start at night, and then as the years go on, it sort of moves earlier in the day. And so it's just easier just to cover you the 24 hours than just to keep moving the medicine earlier in the day. So the sleep fragmentation, like we talked about, when your meds wear off, then your motor symptoms come back. And many times those motor symptoms include rigidity, difficulty turning in bed. The tremor can come back, and that can wake you up and keep you from falling asleep. You can have dystonia, or dystonia means an abnormal contraction of a muscle, and it can be anywhere in the body. And usually in Parkinson's disease, in the middle of the night, it's in the foot. Your foot turns in, big toe goes up, other toes curl under, and that can be quite painful, difficult to walk to the bathroom at night. But you can also have it in the neck, the calves, or the back, and it interferes with your stages of sleep. So there, we want to be careful, always querying you, like, what's the cause of your insomnia? Like, is it you're having trouble falling asleep or staying asleep? And we want to treat the cause of the insomnia. Is it restless legs, or is the RBD waking you up, or is it sleep fragmentation? And we need to increase your levels of dopamine instead of just giving you a Band-Aid and say, here's a sleep aid. We want to treat the cause. And if we treat the cause, then, that those symptoms improve. And in Parkinson's disease, the most common cause of insomnia, the one that wakes you up in the middle of the night, is sleep fragmentation. So we use once a day medicines. We'll add some levodopa in the middle of the night. We'll switch to Rytary, which is a longer acting form of your levodopa. We can use DBS for patients who are having a lot of breakthrough tremor or dyskinesia. We can use pumps like Duopa. And then next year, we're going to get 3 new sub-Q pumps. So for the patients who have said no or rejected Duopa because of the PEG-J, the new version of these pumps are going to be sub-Q, just like the insulin pump. And then those we're going to run 24 hours a day. So you're less likely to have those dips and off periods in the middle of the night. For patients who have trouble turning in bed, we can use satin sheets and bed straps to help you get out of bed. And then we like to avoid coffee and alcohol late in the day. Again, remember that causes more urination and waking you up in the middle of the night. Sleep apnea is very common in Parkinson's disease, so they can have either a central, which is the most common, or a peripheral version of the sleep apnea. So it occurs in about 50% of the PD patients. Usually it's central form in Parkinson's disease, and we diagnose that with a sleep study. And now you guys can have the sleep study done in your own home. You don't have to go to the sleep center and sleep in a weird bed anymore. And that can contribute to excessive daytime sleepiness, especially if you wake up with a headache in the morning. And then we treat that with CPAP or a BiPAP, which patients don't really like that much because they feel like they have this octopus stuck to their head. But it just oxygenates the brain better. You get a better night's sleep. And then sometimes if you're on clonazepam, which is one of the drugs that we use for RBD, that can worsen a central form of sleep apnea. So always with all of our drugs in Parkinson's disease, because they're purely symptomatic, we always want to make sure that the benefits of the medicine outweigh the side effects of the medicine. And we're always making those trade-offs that we want you to have enough meds on board that you're mobile, but not so much that you're super sleepy during the day or you feel like you're going to faint every time you stand up. And so that's what we're always tinkering with your medicines and always making those trade-offs. And so nocturia, or going to the bathroom in the middle of the night, having lots of bladder symptoms, is common in Parkinson's disease. Remember, the bladder is part of the non-motor problems of PD, and you can have urgency and frequency. And many of the drugs don't work that well in Parkinson's disease because it's not really a problem in the bladder. It's with the brain sending the message to the bladder. And many of the bladder medicines cause more side effects in our PD patients. It causes cognitive side effects and trouble with orthostasis or feeling dizzy when you stand up. So we many times use non-pharmacological measures. So like avoiding evening fluid intake, emptying your bladder before you going to bed, and then using things like pads, depends, condom catheters, or a bedside commode so that you're less likely to fall if the commode is right next to your bed and you don't have to walk all the way into the bathroom when it's dark and you're off your meds, you're wearing off. Depression and anxiety, again, part of the non-motor symptoms of PD, are very common in Parkinson's disease and can commonly affect trouble with sleep. So it affects the sleep quality, can cause insomnia. It's important that we always treat those non-motor symptoms, because we haven't really done you any favors if we've gotten rid of your tremor, but you have a lot of anxiety or depression, and you're less likely to get out of bed and go do stuff, even though the tremor is well controlled, if you have an untreated depression. So in many patients, remember, when your levels of dopamine are low, that means serotonin and norepinephrine are low as well. So we want to use an antidepressant that brings that serotonin and norepinephrine up to where it should be. Because remember, your levodopa only increases that dopamine, not your serotonin and norepinephrine. Again, remember the microbiome, those little good bacteria are there helping you make those neurotransmitters. So again, one more reason to eat that fruit and fiber, so that we're feeding the good bacteria that helps us with all of these other things. So we want to maintain good sleep hygiene. What happens in many PD patients is that you're awake during the night and then you're sleeping all day. And so you've switched your sleep-wake cycle, and we have to get you back on a regular schedule again. And then we know that physical exercise helps you have better sleep during the night. So we want to do a little bit of exercise either in the morning or early afternoon to help you with sleep.
Dr. Ospina, real quick before you move on from sleep, we had a question about whether Cinemet can cause fatigue. This person says they take it 4 times a day, and lately I felt extremely tired all day long. I stopped taking it during the day and feel better.
Yeah, so all of your PD medicines, remember, they make the motor symptoms of Parkinson's better. So things like tremor, rigidity, trouble with gait and balance, they make that better. They make all your non-motor symptoms worse. So they can make you sleepy. All of them cause excessive daytime sleepiness. The dopamine agonists more than levodopa, but so does levodopa. They can make you more constipated, they can make you confused, they can make you hallucinate, they can make you compulsive, they make you dizzy because they lower your blood pressure. So that's why we said that always we want to make sure that the benefits of the medicine outweigh the side effects of the medicine. And it's the reason why your doctors tend to be a little bit more conservative, so that if you come in and you say, I'm fine, my medicines are working fine, I do have a tremor, but it doesn't bother me, we're going to just sort of leave the meds where they are instead of increasing your medicines to control the tremor and causing more things like excessive daytime sleepiness. So we only increase the medicines if those motor symptoms are bothering you. So there you would say, how much does the tremor bother me, and how sleepy does the medicine make me? And we want to be on the least amount of medicine that gets the job done. So in that case, if you felt better off the Cinemet, then you could just stay off of it or on a much lower dose. And so dementia, again, dementia is part of the non-motor symptoms of PD. About 40% of patients with Parkinson's disease 15, 20 years later develop a dementia that looks very similar to Alzheimer's disease. And that can disturb sleep quality. It causes patients to be up at night, wandering and hallucinating, or what we call sundowning. And so for those patients, we can treat that sundowning with medicines like Seroquel or Nuplacid, and lower their other doses of Parkinson's medicines to help you and basically your caregiver get better sleep. But that's why you will need a caregiver or somebody there because the spouse can't do everything by themselves. So you can't be up all day and all night taking care of the patient with dementia. So if you are going to live at home with Parkinson's disease and dementia, you need to have help at home and have a caregiver or go into assisted living so that they can better take care of you. But sundowning is very common in PD patients, and it's one of the problems that causes the most difficulty, the most phone calls that we get is treating that sundowning. And so insomnia, so as we said before, it's important to treat the cause of the sleep disturbance, the reason why you're not falling asleep or staying asleep. Is it restless legs, RBD, sleep fragmentation, and treat that instead of just saying here, here's some sleep aid and be done with it. So we don't want to put a Band-Aid over it. We want to treat the cause of the sleep disturbance and get rid of it if we can. So recess, what else did we do in kindergarten? We had recess. And so exercise is super important in Parkinson's disease. Remember that we said that these medicines are purely symptomatic. They don't stop or reverse the disease. They don't cure the disease. They just treat the motor symptoms. And as we found out, they make the non-motor symptoms worse. And so now we think that exercise, remember how we said that by the time you get diagnosed with Parkinson's disease at your neurologist office, 60% of those cells that produce dopamine have already died off. So that means that you still have 40% of those cells that produce dopamine are still living, and we want them to stay living and producing dopamine for as long as possible. And so we know that exercise, and specifically aerobic exercise, that's the one that gets the heart rate up. That's the one that makes those cells make new connections. The more connected they are, the more robust and healthy they are, the longer they live, and then hopefully the slower the progression of the disease. So exercise, I always tell our patients, exercise is going to do more for you than any pill we can give you. So what does exercise do? It increases our levels of neurotransmitters like noradrenaline, serotonin, dopamine, and then BDNF. So what's BDNF? So that's brain-derived nerve growth factor. So think of that as like the Gatorade for the brain. It helps your glial cells, those nerve cells, keep your neurons living as long as possible. So if we give them more Gatorade, they're going to do a lot better. As we exercise, we improve our reaction time, which we know in Parkinson's is slow. You have bradykinesia, or slowness of movement. So we can improve your reaction time. It improves your mood, increases your focus and attention. And that specific part of the exercise can last up to 2 hours. But we know that exercise is very beneficial, both short-term and long-term. And that's why, doing something like rock steady boxing is really good, because you're going to get not only resistance training, but aerobic training, and then you're yelling out. So you're getting your LSVT at the same time. And then there's cognitive things because you have to do a sequence of boxing events. And so that all helps the brain. And then we now think that exercise can lead to neuroplasticity. So that, remember, that means that we can make new connections. So the more connected those little neurons are, the longer they're going to live. And that's what we want to do. So we can know that neuroplasticity can lead to changes in the anatomy, physiology, and the function of the brain. So we want to make as many. So just if one network was taken out, so think of it, your I-10, there was a car crash there and everything's blocked off. But then if we can get on the 202, we can still get to Gilbert or where we need to go. And so that's what happens with neuroplasticity. You've dropped off some cells, but now we're going to make a new lane and get to where we need to go, making new connections. And that's how exercise helps us. And just like we want to have a well-balanced diet, we want to have a well-balanced exercise program so that we have aerobic exercise for the brain and then resistance training for the muscles and the bones. So remember, in Parkinson's disease, you have bradykinesia, or slowness of movement. And so it's not that, your muscles are moving slower, but there's nothing wrong with the muscles. The muscle is still working fine. It's just getting a slow message from the brain. But if the muscle stops moving, it starts to atrophy and waste away. So we want lots of resistance training to keep those muscles nice and strong. And then it turns out that when your muscles, they push and pull on the bone, that's what tells the bone, hey, I need to absorb the calcium in my diet or my supplement and deposit it in the bone. If the muscle isn't pushing and pulling on the bone, then that calcium just leaches out and it goes into the urine, and your your calcium pills that you're taking are just getting excreted in the urine, and all you have is very expensive urine. So for those calcium tablets to work, or the calcium in your diet to be absorbed into the bones, you have to do some exercise, some resistance training to actually deposit it in the bone. You just can't take the pill and watch Netflix. And so that's why we want resistance training to keep your muscles and bones strong. And then those quadriceps, those are the muscles that get you in and out of a chair, in and out of bed, in and out of the car. And so we want to keep them nice and strong so you don't get weak. Exercise also helps us with balance. So if we can strengthen your core muscles, that we're going to improve your balance, which we know is impaired in Parkinson's disease. Patients are retropulsive. They tend to fall backwards, and that's why they kind of plop in the chair. And if they sit in a deep sofa, they have to be pulled up because they just don't have those core muscles are not as strong as they used to be. So we want to improve your balance to prevent falls in the future. And the other thing is, if we can keep you from getting that stoop posture and keep those core muscles nice and strong, then we can help your speech as well. Remember, your diaphragm is a muscle that bellows the lungs to take in air and out. And so that way you can project your voice out farther and louder. And so by doing that exercise and keeping your core muscles nice and strong, we can have a better balance, better posture, which is also going to help your speech and swallowing. The same thing with the swallowing. Patients with Parkinson's develop trouble with swallowing. So you're more likely to choke on your food or aspirate your food where it goes down the wrong pipe. And again, if we can keep you upright, then you're less likely to choke on your food. And remember, what happens in PD, we always are sending you to have swallow studies to make sure that we're using the right consistency of food. And so in Parkinson's, we want to have small little bites. We want to chew them up really, really well. We want to alternate liquids and solids, so you're always washing it down. Always eat sitting upright, no eating in bed, and then no talking while eating. And that way we're minimizing your aspiration risk. So there's this little flap here. And that if you're talking at the same time as you're eating, this flap, remember you have bradykinesia, it's very slow. If this takes too long to close down, then your piece of steak gets stuck there, and then you choke on your food, or you aspirate the food and it goes into the lungs and it causes an aspiration pneumonia. So that's why you want to have good posture, and the exercise helps us with that. And then, of course, exercise helps cognition. So we know that habitual exercise compared to sedentary subjects, those are the ones who are popping their calcium pill and watching Netflix, have a greater dopamine release and greater activation of their dopamine pathways. So remember, we want to keep your brain stimulated, and your brain gets stimulated by learning new things, but also through physical aerobic exercise. What else does exercise do? It improves your mood. So remember, we're releasing serotonin, norepinephrine. That's that runner's high. What's the best thing about the exercise, and what did we notice during the pandemic, is that when patients were no longer able to go to the rock steady boxing classes, the neural wellness centers, and their physical therapy, they lost that social interaction. And patients became anxious, depressed, because they were sort of stuck at home. And so we need that social interaction to have a good quality of life. And then we know that interaction helps us with not only the immune function, but also has anti-inflammatory effects. So again, that's why we want you to get out and go again. And I think, in our next pandemic, we might not close down everything and know that with our Parkinson's patients, they need a little bit more socialization, and they need to get out and go to their neural wellness centers and not be doing Zoom classes at home. So what are the goal of, and so we really like rock steady boxing because you get all of those things. So you get aerobic exercise, you get resistance training, you're yelling out your things. So you get your LSVT, you get your cognitive stuff in because you're figuring out how to coordinate all of the movements, and then you're in a group. So you have some social interaction so that you become friends with the other people in rock steady boxing. You dress up for Halloween, you have birthday parties together, Christmas parties together. So it's very good. So we like rock steady boxing a lot. And then big and loud and power gym, we use that in Parkinson's all the time for physical therapy and speech therapy. You can also do music therapy. Things like tango and tai chi are also very good for balance and freezing of gait. And of course, every time you do it in a group, then you get extra brownie points. And then remember how our medicines, they only treat the motor symptoms of PD, but exercise helps non-motor symptoms of Parkinson's as well. So it improves cognition, improves your mood, it helps you with constipation, it helps your voice, it helps your swallowing. So we like that because it may be neuroprotective and it helps both non-motor and non-motor symptoms, as well as not just your motor symptoms like the medicines. And then it's not going to make you sleepy the way dopamine agonist and your Cinemet does. And so then many times they say, well, what's the minimum amount of time I need to exercise to get these changes? Of course, we want you to exercise every day, but the minimum would be at least 30 minutes of aerobic exercise 3 or 4 times a day. But ideally, you should be doing some form of exercise, whether it's walking or something, every day. And so this is, what we talked about before is these are the same changes that we see in the Parkinson's brain. So, this is your substantia nigra. This is where these dopamine cells are living. Here's a normal patient. It's nice and dark. Here's a patient with Parkinson's disease where we've started to lose those dopamine producing cells. We don't have as many cells there with melanin. So here's a normal patient here. And then here's a patient with loss of dopamine producing cells. But we still have these little cells here. So we want to keep these cells living as long as possible. And we know one way to do that is to do that aerobic exercise for them to make new connections and keep themselves strong and healthy. And then here's the famous Lewy body. So a Lewy body is what we see under the microscope when we look at a patient's brain who has Parkinson's disease. And a Lewy body is made of this alpha-synuclein, this misfolded protein that got misfolded through that whatever toxin came through that leaky gut that caused that alpha-synuclein to misfold. And then that alpha-synuclein works like a prion and marches up your vagus nerves and make it up into the brain. And then your cell, because it can't clear the misfolded protein, it puts it into a little garbage can we call a Lewy body, and it sticks it in there because it can't get rid of it. So that's what the famous Lewy body looks like. Oh, and then we gave the answer already. So what's the only mammal that we know that has a pale substantia nigra, one that looks like this? It's actually the three-toed sloth of South America. So this mammal is very slow. It's bradykinetic. And guess how many times it goes to the bathroom in the week? It only has a stool once a week, so they're constipated. So they have bradykinesia, constipation, and their substantia nigra looks like this. So it's the only mammal that has pale substantia nigra. That's for your extra Jeopardy points. Okay, and then here's just, what causes the motor, so why do PD patients develop motor complications? Remember that the normal brain gives you a continuous infusion of dopamine over the 24-hour period. It doesn't pulse you with dopamine every 3 or 4 hours, which is what we do with levodopa, because it's a pill that you swallow every 3 or 4 hours. And so that's what causes those motor fluctuations where you're going on and off, on and off. And so that's why we're so excited next year that we're going to get 3 of these pumps where you're going to have a continuous infusion of dopamine. Well, 2 pumps are levodopa and 1 pump is apomorphine. And we're going to avoid these peaks and troughs that you're going to be getting throughout the day, so that instead of peaking and troughing, it'll be like the insulin pump where you can give you a steady infusion of dopamine and keep you sort of steady in this therapeutic window as long as possible during the day and as the disease continues. So remember, when you first get diagnosed with Parkinson's disease, we're way over here, where your therapeutic window is quite large. You still have 40% of those cells that produce dopamine. They're still living, and you're able to absorb that dopamine from your levodopa pill or the Rytary and then buffer it and use it for later. But as those cells continue to die off, then you lose that buffering capacity. And then you notice that the metabolism of Cinemet or levodopa is every 90 minutes, and that you're peaking and troughing either above your therapeutic window, you get on time with dyskinesia, or you're below your therapeutic window and you have off symptoms. Your symptoms have returned, like tremor and rigidity. And dyskinesia means involuntary movements. So those wiggly movements that you've seen Michael J. Fox have during if you see him on television. whereas the tremor is a fast rhythmic movement. And so what we always tell patients that when you start over here, you've got a savings account of dopamine and a checking account of dopamine. Your checking account is the pills that we give you, and your savings account is the dopamine that you're still able to make. But as the disease progresses, we're gonna keep losing money in that savings account. And so that eventually, and initially, every time you wear off, when you're over here, it overdrafts and it takes it out of your savings account. And so you don't really notice. So initially, when you start Sinemet, you take one tablet 3 times a day. If you're 30 or 40 minutes late with the medicine, you don't even notice. You could even miss the noon dose and nothing happens. But as you've overdrafted all of the dopamine out of your savings account, then you notice that every time you were off, every time you overdraft, then you're in the off position, and that we have to add more medicine, more money into the checking account to get you back into this therapeutic window. So our goal is to use longer acting forms of medicines and once a day medicines to keep you in this window, especially as the disease progresses and this window gets narrow and narrow and you're bouncing up and down and having what we call the motor fluctuations. So any questions that you have about this? If you understand this graph, then you understand, what's happening in PD and why your doctor is choosing the medicines that they're choosing.
There is a question. Someone just wrote, do these pumps reduce the need for DBS? So
the pumps will push off the need for DBS. So, right now, when we offer patients Duopa or DBS, 9 times out of 10, they're still choosing DBS first, which as a clinician would not be our first choice. Our first choice would be to use the least invasive reversible procedure first, and then go on to the surgery. But because patients really don't know anybody who've had Duopa, there's nobody in their support group with Duopa, and they know 2 or 3 people in their support group with DBS, they've known about DBS for 20 years, they still choose DBS first. I think that will change once the sub-Q pumps come out and they're much easier to use and more people will be on it. So you'll be on a pump first, and then if you develop on time with dyskinesia or some other fluctuation that we can't control with the pump, then you would go on to DBS. So just like Rytary pushed off DBS a couple of years, these pumps will also push off the need for DBS by a couple of years.
And does rasagiline help with off periods? Someone just wrote.
Yep, so rasagiline is an MAOB inhibitor. So remember, there's levodopa, so there's Sinemet and Rytary. Rytary is a longer acting form of levodopa. And right now there's 2 enzymes that chew up your levodopa in the gut. So there's dopa decarboxylase, which is what carbidopa inhibits. And then there's COMT, which is medicines like Ongentys or entacapone or Comtan. So we can block both of those enzymes in the gut and get more levodopa to go up into the brain. And once your levodopa makes it to the brain, it turns into dopamine. And that's where rasagiline works. It inhibits the metabolism of dopamine, so it hangs around in the brain a little bit longer. So we like to start Sinemet or Rytary. Actually, we like to start Rytary, the longest acting form of levodopa that we can get our hands on. So we're not peaking and troughing so often during the day. Add a COMT inhibitor so that we can push up more of that levodopa from the gut into the brain. And remember that if we're not blocking COMT, again, remember that amino acid little elevator that you have in the gut. So not only does protein compete with that elevator, but so does 3-MD, which is what COMT metabolizes your levodopa to. So if we can block that, then there's less competition through that little amino acid elevator, and more of the levodopa can get into the elevator first and make it up into the brain. So we use a long-acting levodopa, add a COMT inhibitor, we can then add an MAOB inhibitor, we can add a small dose of a dopamine agonist. But once we use the pumps, our goal of patients who are on the pump, so if you're on levodopa more than 4 times a day, instead of adding all these extenders and adjuncts to make it last longer, instead of taking your medicine 5 times a day, then you would go on a pump and then try to go back to monotherapy. So if patients who are using levodopa 6-7 times a day and they're on polypharmacy, they're on rasagiline, they're on Ongentys and Nurians and Mirapex, then our goal would be to go on a pump and to try to get back to just once a day medicines, just levodopa, avoid all the side effects from all the extra medicines, including to your pocketbook, because as you know, all of these new drugs are extremely expensive. And then the nice thing about the pumps is that most likely they will be covered by Medicare A and B. It's not going to come out of your Part D, so that you shouldn't have a copay like you do for the pills. Like Duopa and DBS patients don't have any copay. And so that would be one way to minimize your financial burden and also your sort of medication burden and side effect burden, if we can go back to monotherapy and keep you on a long-acting form of levodopa. So think of it like type 1 diabetes. We no longer have patients on sliding scale insulin, all these extra stuff. We just put you on a pump with a CGM and then you do quite well. And then you just put the pump on and you forget about your diabetes. You're not doing finger sticks all of the time. And that's what our goal is in Parkinson's disease, to use the medicines while it's still easy, 3 or 4 times a day, and then to transition to a pump and not have 6 or 7 alarms on your phone and have 3 or 4 different types of medicines for Parkinson's disease. So it's all exciting stuff coming next year. So any other questions do you have about this, graph here?
Not specific to that graph. We have other questions. One in regards to exercise, and that was in regards to Cinemet. Can that cause water retention because this person's legs swell to the point where it does affect their walking and therefore exercising?
Yeah, so there's many reasons why you can have leg swelling or leg edema. So you want your heart and lungs checked out by your primary care doctor. So the Cinemet itself is not going to cause swelling of the legs. So things like dopamine agonists can cause swelling in the legs, and that can interfere with exercise. But the levodopa shouldn't. What you may notice, so think of your levodopa. So it's like gas in the car. So if you drive your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. And when you go to rock steady boxing or you go to exercise class, you're going to burn through that levodopa faster than on days that you're just sitting at home watching TV. So you'll notice, that's the reason why some days your medicine lasts longer than others. It all depends on how much stress your body's under, both physically and emotionally. So if your dog died, your kid got a divorce, that's all going to impact your absorption of levodopa and how long it's going to last during the day. So that's why you notice that some days the medicine lasts longer than others. And that's why it's really important to treat your body, not the clock. So it's your body that has Parkinson's disease, not the clock. So if you went to rock steady boxing and you were off early and you were off here, and it's 11 o'clock, but your next dose is not until 12, and you waited until 12, which is way down here, to take your next dose, then it's going to take you a really long time to get back into the on position. So we want to treat you right over here. So as soon as you were off, that's when you either want to take your next dose of medicine or use an on-demand therapy, like things like Ambrosia, Kinmobi, or Apoquin, that bypass the gut and kick in quickly and get you therapeutic right away, instead of spending too much time in this off or this trough and having more off time during the day. So again, our goal is to minimize the amount of off that you have during the day and keep you in this therapeutic window on, so that you're not planning your day around your doses of medicines and your off periods. So what else did we learn in kindergarten? In kindergarten was to play nice with others. So always be a good friend. And so, what did we learn from the pandemic? Why did our patients do so poorly during these 2 years of being stuck at home and not seeing their friends and family? So as humans, we evolved to seek safety in numbers. So if you're not with other people, your brain registers that as loneliness, and loneliness is registered as a threat. And loneliness is defined as the gap between the level of connectedness that you want to have and what you have. So there's many people that are introverted and loners, and they're fine, being, without seeing anybody over the weekend. And then there's extroverts. So it all depends on what you feel is loneliness to you. And so we know that loneliness causes a greater risk to your health than smoking. So being lonely is equivalent to smoking 10 cigarettes a day. So it has a huge impact on patients' quality of life. And then when your brain recognizes things as a threat, it releases those stress hormones, that fight or flight hormones from the amygdala, which causes more inflammatory response in the body, which we want to get away from in Parkinson's disease, because we think that high inflammation is what causes that cell death. So we want to avoid the inflammatory cells and fewer antibodies. And so once you have more inflammation in the body, you have fewer antibodies, and then you're more likely to get things like a virus like COVID and colds and the flu and that sort of thing. And then what else happens when we're stressed? So these are little chromosomes. This is what is in our DNA, and this is what carries sort of our genetic material. And so these chromosomes, for your cells to divide, they have to sort of replicate themselves and divide, and then you get two different cells, and that's how you get new cells or new stem cells. And so it's the reason why we develop sort of wrinkly skin and white hair, is because we lose those stem cells. Those cells are no longer able to divide and stay young and healthy, and they start to senesce and get old. And in order to divide and make new cells, you have to have these little telomeres, these little yellow spots. Those are the telomeres that allow those chromosomes to replicate themselves, to divide and replicate themselves. And so the longer your telomere is, the more times that cell can divide and the more youthful that cell is going to be. But we know that stress can reduce the length of the telomeres. So the more stress that you're under, the shorter the telomere, the less divisions that cell has, the faster that cell is going to die. And we know that for patients who care, for caregivers of patients with chronic disease, when you are stressed out, you actually sort of age in dog years, because those telomeres get smaller and smaller. And think of the telomeres like, you have some shoelaces, and it's sort of the plastic part at the end of the shoelace. So it keeps the shoelace from sort of unraveling and breaking apart. But the longer it is, the more divisions that cell has, and the longer that cell is going to live. And so that social networking buffers these little telomeres and makes them last longer. That's why we say it's important to exercise in groups, because we're making these telomeres last as long as possible. And we want to avoid stress, because that shortens your telomeres more. So that's why we like to exercise in groups, to keep those telomeres young and healthy, and keep them as long as possible. And as we know, cooperation has always been the key to our success as a species. So the more we cooperate, the longer our species is going to live, something we all need to learn. And again, social connection is good at treating both the motor and non-motor symptoms of PD. So it's going to help with anxiety, depression, cognition. The more you eat in groups, if you're eating your vegetables with your other friends, you're more likely to eat your vegetables. If not, you're going to sit at home and eat your donuts and ice cream. And so what did we learn today? So we want to feed our microbiome. Remember, our microbiome is talking from our little gut to our big brain. And we want to keep that leaky gut. We want to keep it working as we don't want a leaky gut. We want to keep that mucosal lining working as long as possible. And we want to feed that microbiome lots of fruit and fiber, because that's what the good bacteria want to eat. And then we want to exercise, because exercise not only helps us with the motor symptoms of PD, but with all the non-motor symptoms of PD. And just like we want to have a well-balanced diet, we want to have a well-balanced exercise program. So that we have aerobic exercise for the brain and aerobic exercise for the muscles and the bone. And we know that sleep is medicine. So sleep is when all the restorative work is happening in the brain and the body. So all the healing is taking place. You're pushing out growth hormone, short-term memories turning into long-term memory. And you're getting all of the housekeeping done in the brain. And then we want to lengthen our telomeres as long as possible. And we know that social interaction is a good way to do that, and it reduces stress. And so what questions do you guys have?
Well, you've answered quite a bit of them. So I'm trying to go back to look and see if there's anything. There was one in regards to the Metamucil, because we talked about that at the beginning. And someone had written earlier that it had been cited as being competitive for absorption in the small intestine. So is there any information that you can maybe give for some direction on that?
So Miralax works just fine and doesn't really have a taste. So if you just need a cup full of Miralax and put it into a glass of water or juice. And then you want to dose the Miralax so that you have a regular bowel movement and it comes out like toothpaste. Not that you are constipated. So if you're having small little hard balls, you're constipated and you need more liquids. And if you have loose stools, then that's too much. So you would adjust your dose. So some people need a cup full, some people need 2 cups full in a day. Some people need to take it every other day or every third day. So depending on how much fiber you have in the diet, then you figure out how to adjust the dose of Miralax.
And, you know, honestly, you've covered so much. I have to say a lot of the comments are just about how fantastic this program has been, and this dog is adorable, so we would love that. And really a lot of them were around things that you've pretty much have covered. So you got a 12 out of 10 on this today. So I think you've hit the nail on the head. I know that we've gone over, and I know you have patients that you still have to see. So I don't know if there's any last statements that you want to make to kind of, you know, cap it all off.
So yeah, basically everything we needed to learn, not only for Parkinson's, but for life, is that, you know, we learned it in kindergarten. Get good exercise, take a nap, be nice to your friends, and eat your vegetables. Simple.
And I actually am going to stop your sharing only because I want you to be able to see everyone's faces, because you've done such a great job and in our traditional PMD style. And I know you've been on many of our live streams before, but there's nothing better than seeing the smiling faces and getting the wave of gratitude from all of our people out there from all over. I've seen them all over in Alaska and I think Canada. So you're giving words of wisdom all across the country and beyond. So thank you so much, Dr. Ospina.
You're welcome. It's always fun to see you guys.
Awesome. And thank you everyone for joining us. And yes, it will be recorded up on our website, probably beginning of next week. And there are some links that we dropped in the chat referencing some things that she said or answers to questions that you had for some of those. So you can grab those by going over to your chat box where those 3 little dots are, and you click that box up, it'll say save chat. And that's one way you can access it. It'll save it to your device. So thank you everyone for joining us. Thank you so much, Dr. Ospina.
Sure. And there was a question about the pump. So actually, you know, we're going to do another talk next month about off periods, and we're going to have some pictures of the pumps that are coming out next year, so you can see what they look like next. I think that's sometime in August.
Yes. So like a part 2 sort of. Yes.
Part 2.
Awesome. Well, thank you so much. I hope everyone has a fantastic weekend. Thank you, Dr. Ospina.
Take care. Bye-bye.
Bye.